Thank you. And just checking that people can hear me. Okay.
Yes, we can hear you.
Fabulous. Okay. And then the next check is that this advances.
Yeah, it's working.
Yep. All
Yep.
right. Wonderful. Um, so thank you very much for letting me join. I was hoping to have been able to go out to Boston, but unfortunately my family's not very well, so I'm sorry about that. But delighted to be joining online, and I did manage to stay up till, so I'm here in Sydney. I think about 2:30 and I'm looking forward to listening to the bits that I missed when I was just having a bit of a rest in the middle of the night. So I'm here to talk to you, maybe a bit of a key change back to the more clinical interface between science and clinicals and families, I would argue, and sharing some of our experiences from our Kleefstra clinic that we run here in Sydney. And I'm going to be talking about a few things. Some of them are obviously papers you know and love very well, but also just highlighting some of the resources that I'll be mentioning are on our Rare Diseases New South Wales website. So I'm very happy to share these slides, and that QR code might be helpful for you as well. Um, and I guess I've taken a slightly well, I've been thinking a lot about this, and I think we had a very beautiful talk very early on where we were hearing about the impact of living with rare diseases on families and how that drove the Citizen Health Initiative. And I think it's something that has to underpin everything that we're doing and why we're here and why we, taking time away from our clinics and our research is really that we're all wanting to make that journey better for families. And just some musings on how we've been going in the clinical space and maybe some suggestions opening up for discussion of where we can go. But I just wanted to, as always, I don't think many of you in the room will need a reminder that we're here because of these incredible kids and young people and older people now. We're getting quite a few older people into the clinic now, which is wonderful actually. And we need to remember that these kids bring an awful lot to our lives. In our little Kleefstra Syndrome handbook that we've been putting together, Elle, our nurse, was speaking to families, and there was some commonalities in the amazingness that these kids bring that I think is really important. And I've never seen more determined kids that, despite all the challenges thrown at them, plug on and plug on and plug on. And I think just want to honor them and their incredible families. So yeah, we call them our Cleef stars because they are brilliant. So centers of expertise, I guess I've been thinking about this a lot. We have a government funded project here where we're looking at the issue that the government says to us, well, we hear all the time about centers of expertise and how we need to fund these but why and how might we actually do that? And I think this is the stark statistic that behind every journey that we hear and we'll be hearing shared at this the family conference, is that our health systems, pretty much wherever we live, are failing our families. So rare diseases are expensive, and at the moment, the health provision, I would say, is low value, which means that there are many opportunities that if care was improved, we would be saving the health system money. So, for example, unwarranted emergency appointments that could have been better avoided if patients were getting proper preventative health care. And the statistics are still incredibly stark and incredibly frustrating as a rare disease clinician we don't have more individual health system attention being placed. So six as a pediatrician, this is the statistic that still stops me in my tracks. If we think about childhood deaths, 60% are caused by a rare condition. So we're getting better at cancer, infectious disease, all of those things, and what we're left is with rare disease. It takes a long time to get a diagnosis, and as I'll show, we're really not getting diagnoses into those older years, which is really critical. And most don't have a treatment, and I'm so looking forward to listening back to the talks about the progress that is being made here. But I also wanted to highlight that. So our Rare Barometer insights have just been published for Australia, And 80% of people living with a rare disease, so that's patients and their families, say are living with significant psychological distress. And seeing these figures, you don't have to think why that is. And we've done a lot about sort of mapping that patient and family journey. And the interesting thing is the commonality in the experience across different rare diseases is there. And sometimes when it feels overwhelming, like we're all working across so many different conditions, it's taking a moment to step back and think, if we could bring some solutions to some of these pain points, then we could help so many families. And centers of expertise are definitely, and I'm a firm believer in them, are there as held up as gold standard for many different reasons. I've put them there on this slide, and we think about how they get patients ready for clinical trials. We're bringing our cohorts, our knowledge. We can do natural history studies, but we can also hold the families right now where they're at and connect them with the right clinicians and help put things like guidelines into clinical practice. And a huge part of that and what our nurse spends a lot of time is not actually healthcare. It's finding the disability service. It's helping kids get proper education at school. It's helping, frankly, putting food on the table for many families who are so exhausted and are spending so much of their income with private healthcare appointments that their basic needs are not being met. But they also have a potential about linking us back together again. And that's what I want to come back to, because I am thinking we need to do better at that as clinicians. So I've talked about those, and this is an undersold part of centers of expertise, but one I think it is worth focusing on is we know that as a clinician, I know as a clinician, if I'm working at a center of expertise or can contact one, my heart rate starts going down because I know there are people there who have seen lots of people with this individual condition. And as a clinician, I'm not having to ask them for the first time. You know, they have other families, and that is so helpful as a clinician to have that deep insight and expertise to be shared. So remember, there are 9,000 rare conditions. I see many children with many conditions where there is no center of expertise anywhere around the world. And I think Europe has done an amazing job. Well, certainly from the outside, it looks like Europe's done an amazing job in recognizing the importance, having the kind of legal and regulatory framework. And in some countries, and I particularly would hold up Germany to this, really investing in them at the state and federal level. And as an example, I've seen, you know, the incredible benefit of the Angelman syndrome clinics here. We have managed to attract into Australia every single trial that is running in the States, which I think for such a small and relatively remote country is incredible. And that is down to the perseverance of the Angelman community. So our clinic is here in Sydney, at Sydney Children's Hospital in Randwick. And we're the only dedicated clinic focused on Kleefstra syndrome. And we've seen now, I'm just going to be seeing next week our 30th individual, which I know is not reaching the dizzy heights of the Nijmegen and Boston clinics, but for us, we're pretty proud, and we have patients in every state across Australia. And the referrals keep ticking on in. We have an amazing nurse navigator, so amazing I seem to have named her twice, but this is the bit that I really want to focus on, is funded by families, and in particular one family that did an amazing gala a few years ago. And that, to me, as a public healthcare physician, is deeply shaming that our health system is not funding these nurses that are the lifeblood of the clinics. And it's rested on families fundraising, bake sales to get that over the line, when we know the evidence is there that this makes healthcare so much better. And, you know, as I said, we're pretty proud we're reaching 30, but we should be reaching many more. So what I've done here is looked at the prevalence of what Kleefstra should be, and then what our clinic is reaching, and why are we not reaching all of these families. I think we're pretty good now that families find the clinic, you know, through social media, through IDefine, through Facebook, and then we can get referrals from anywhere else, but we are still not diagnosing many of our patients, particularly our older patients. Our access to more broad genomic testing and the genetic expertise to interpret that is still behind the eight ball. And I'm just, as a comparison, showing you some figures of what Claude at least projected might be the number of patients that are out there in the States. So it's really still a drop in the ocean. I was very lucky to be part of the international guideline initiative that's been talked about several times, and that was incredibly helpful to get that really in-depth knowledge from people like Sid, like Chitska, who are running, multidisciplinary Kleefstra clinics, and also from the families in the room that share their expertise and brought us back. But one of the things I was kind of hoping to have got out of that guidelines was some more support for me to know how to help my patients who seem to have really terrible GI dysmotility issues. Like we have several patients that have needed surgery, who have stomas, and I just wasn't seeing that reflected in the global literature, and I was wondering why that is. And we have a beautiful genetics fellow who's looking across our cohort, and just at what we at least are talking about in the clinic, we're seeing most of our patients have not just one GI motility issue, but GI dysmotility issues across the spectrum, and often a sort of a vicious circle of recurrent infections, antibiotic use, worsening of GI dysmotility, iron deficiency for blood loss, then given iron medication and things get worse. So it's not being well managed. And I guess then we've reached out, and it's wonderful, is one of the things that's come from the guidelines is, I have the emails, maybe this isn't wonderful for them, I'm sure it's not, of many of my colleagues, and I can ask them, and we're setting up a little sort of mini task force to really focus on that as well. So I think that's a really important thing, and I guess that's been alluded to at some of the earlier talks, your today, my yesterday, is that we as clinicians are sort of trained to think and look for certain things, and we really need to let the families, and as I was hearing the electronic medical records, tell us what's really shaping the day and what are priorities, and both of these perspectives I think need to be looked at. So as I said, that international guideline experience was incredible. They flew me out to the Netherlands. We met in the room. We were there literally around a table. And it was so incredible to have that community of us all thinking and problem solving together. But I think we need to try and think of how we can keep that going forward, because we still have so many unanswered clinical questions and such a need to share that beyond our individual clinics, particularly if we're thinking about global equity. And what we've been doing locally is thinking, how can we get that gold mine of information from the guidelines into clinical practice across Australia? So we've developed a family-centric guidebook that has all of the information in plain English for families. We've got a page on our Australian Rare Disease portal that summarizes that. We're also, each of our families, when they come to clinic, leave with a document which has the most salient bits of that guideline, how it's relevant to their child, and how that can help if they're going to emergency department or seeing an anaesthetist, so they've got the information that they need. And we're also very much trying to make sure our patients all have the opportunities to participate in global research. We've got getting consent for recontact, for phenotypic information, and for cell lines. Every time a patient has a general anesthesia, we try and get a skin biopsy from our patients so that we can participate in the global effort. So, and I guess one of the things is we're distilling that information, and with my other hat on it, the co-founder of Rare Diseases New South Wales, we're thinking and looking at that experience and how that can help other children with neurodevelopmental conditions, but also bring that information from other specialist clinics back to our Kleefstra clinics. So we're just really proud that we've soon to launch these rare passports, which are templates and fill-in guides for clinicians to bring those kind of key bits of information for any child living with a rare disease anywhere across Australia. So maybe that's the answer. We've got the answer, centers of expertise, but we've got a problem in that we've got more than 9,000 individually rare conditions. So yes, I see kids with Kleefstra syndrome, but I see kids with P10, I see kids with tuberous sclerosis, I see kids with WAWOX, I see kids with numbers of combinations of letters and numbers that you will have not seen every day, new diagnoses. So how do we possibly think about scaling this? And I guess what we're going is we also need to think about ourselves and our protecting our health workforce. And that my colleagues and my friends and quite frankly often me, we are stretched very thin because we work generally in health systems that are not designed to help us provide the care that we want to. So we did a little a survey and some interviews among the cohort of clinicians in Australia looking after patients with severe epilepsy. And 70% of us were burnt out. The more patients with rare conditions we saw, the more burnt out or heading to burnout we were. And most people were thinking about exiting the clinical profession. And they didn't want another resilience training. Clinicians wanted the support of the infrastructure of centers of expertise, particularly the nursing staff, the social work, the psychologist staff that could help them do the job that they wanted to do. And I'm just going to pause on that for a moment because I think I almost feel embarrassed bringing it up, but I think it's important that we bring up if we're thinking how we can go forward. So I'm coming to an end. What we have been thinking about in Australia is how much can the individual state health systems hold in terms of the cross-disease infrastructure. So building the registries, connecting the registries, the clinical trial infrastructure, the psychological support. You know, think about a child with cancer and the wraparound care that comes into play, whatever their individual cancer diagnosis. Our kids and adults deserve that. But then they need to be linked with individual centers of expertise. And for many conditions, they might not be in your country, but a way that we can connect up, the rare disease community in India, in the Philippines, in Somalia, when they have a child diagnosed or an adult diagnosed with the international centers of expertise. And I guess that was one of the things that many of us at the end of the conference were kind of musing about. It would be so wonderful if we could keep the conversations going. And I'm just thinking incredibly guilty that I send off emails all the time, and that's probably not the most time efficient way. I'm sure Chichka would and Sid would agree that they're probably in dismay every time they get an email from me. But could we think about some forums? What are other rare disease specialist clinics doing to keep that contact going and to share that with the rest of the world where there isn't a clinic available? And one thing I was thinking about earlier is that idea of we're collecting data in a very similar way so we can share and cross and get those insights into which anti-epileptics are working as we're developing the advanced therapeutics. And what would enable that, quite frankly, and why it's not happening, is probably some investment in some basic administration staff to help that bring together. And again, that's what I've seen so often is if you invest in a few people that take the organization role over, and that's what the European Reference Network did so beautifully with the guidelines, then it will happen. And I think that's something else I was suggesting. I think we also need to think about how we get the message to every single clinician around the world that they need to look at the guideline and they need to think about making sure their families are enrolled in the natural history studies and part of this incredible community. And that as we're becoming trial ready, we are listening back to the families and picking outcomes that are going to be set us up for success, and also what are the most important things to those patients and those families. So this was my suggestion and my call to action at the end. I'm finishing up here. I think the therapeutic window or the opportunity is opening up for us in Kleefstra, and we on the clinical side need to meet you as the scientists to be ready. And I think that connection is how we're going to do that, and partnership with families. So thank you very much today. Hopefully, I know we started late, but